right. In our last chapter, we looked at the types of bones and bone cells and cartilage that is on the ends of the bones. Like, what all was that for? Well, we're going to look now at articulations, or where the bones meet each other, or more commonly, we would call them joints. So here's our objectives. Pretty simple. We want to know what the joints are, be able to identify them, and talk about their structures. So let's first start with what is an articulation or a joint. Most simply, it is just a place of contact between two bones, between bones and cartilage, or bones and teeth. And there is a whole study called anthropology, which is the study of joints for the articulations. And we're going to classify these joints based on their structure and on their function. So while we've been doing a lot of the anatomy of bones and where they are, this chapter does have some of that, like the parts and pieces of joints, but it is a lot more focusing on the physiology aspect. Let's first look at the structures. What do we have? You can have a fibrous joint. That is bone that is held together by dense connective tissue. You can have a cartilaginous joint, which is bones that are held together by cartilage, or you can have a synovial joint, and that is bones joined by ligaments with a fluid-filled joint cavity that separates the bone surfaces. If we're looking at their function, then we can have what we call a synarthrosis, which is immobile joints that are usually fibrous or cartilaginous joints. We can have an amphioarthrosis, which is a slightly movable joint, which is usually fibrous or cartilaginous joints. Or we can have a diarthrosis, which is a freely movable joint. All synovial joints fall under this diarthrosis category. So, range of motion, what do we mean by not movable to full range? So, basically, we have a spectrum where we range it from no movement at all to extensive movement. And the structure of each joint is going to determine how movable or how stable the joint is. And there is this inverse relationship between mobility and stability. Like, for example, you could have something like the skull, which has joints that we call sutures. They're immovable. It's a fibrous joint, but it is incredibly stable. On the very opposite of that, you have something like your hip, which is a synovial joint. It's incredibly movable, but as you may know from having relatives or yourself, like, you can damage and injure that joint pretty easily. So that's that inverse relationship. And this is a diagram from your book showing you exactly that. So you can have something like a stable but limited mobility. Things like your skull, or the membranes between like your ulna and your radius. You can have a cartilaginous joint like your vertebrae. And then you get to things like your knee joints or your shoulder joints, or your hip joints that are freely moving but way less stable. Let's start with our fibrous joints. What do we have going on there? They're connected by dense, regular connective tissue. They do not have a joint cavity. They are immobile or only slightly movable. And there are three types of fibrous joints. We can have our gomphoses, sutures, and syndesmoses. Let's first look at the gomphoses. That's like a peg in a socket type of joint. And we really only find this at the articulations of teeth within the sockets of the mandible and maxillae, so your jaw. The tooth is then held in place by this very fibrous periodontal membranes. And really, it's this synarthropes. We're not really having much movement, if any, in this type of joint. You can have something like a suture that is between skull bones. They're very short fibers that hold them together, and they have these interlocking irregular edges, almost like little puzzle piece that sticks together. And really, this increases the strength of that bone joint or suture and decreases the risk of fracture. It's going to also function as that arthropes, really not much movement, if at all. And really, there is growth that happens in childhood, right? We had those soft spots or fontanelles we talked about in the last chapter. But it does become ossified and become that synostoses as we become older adults. We can have those syndesmoses, which is where we have this membrane that is holding together two bones that are closely, I guess, closely related. So something like the the ulna and radius, or the tibia and fibula, those are going to have this interosseous membrane, this ligaments holding them together. This is going to work as an amphioarthros, sort of movable, but not much. It does provide a pivot point. So the fact that you can hold your arm in front of you with your palm down and rotate it to put your palm up, that is that pivot point. And we've got a little video here with our types of joints. This is also in the D2L. I was just taught this function, so let's see if we can get it to play and you can hear it. We'll find out. Just kidding, it won't play for you. Oh, it will. We'll pause that there. I'm pretty sure I embedded this video again for us to look at after we look at the types of synovial joints next. I'm just excited that that worked because the training I've been doing during the day has made sense. But let's go ahead and look at these cartilaginous joints. They have either hyaline cartilage or fibrocartilage between the bones. They do not have a joint cavity around them. And so they are immobile or just slightly movable. And that's that synchondroses or symphysis, like in your pubic bone or when you are a child at your growth plates. We can also see here at your ribs, you'll have this intercostal cartilage. That's the cartilage that's between it and the sternum, and that is another type of this synchondroses joint. So again, immovable or very slightly movable. The symphysis, that's the pad of fibrocartilage that is between the bones, like in your pelvis, or in the vertebrae in between them. So that's very slightly movable. An interesting thing that we want to talk about is costochondritis, which is actually an inflammation of those costochondral joints, like in your rib cage, and it causes localized chest pain. And we don't always know the cause of it. It could be trauma or infection, but it is something that can be mistaken for a heart attack or a myocardial infarction. So if someone comes in with chest pains, automatically people usually think, oh, like heart attack, but it could be something less serious. And then this is treated with a anti-inflammatory non-steroidal drug. It can be injected or taken by mouth. Okay, synovial joints. Like the little video said, this does really encompass most of the joints or most of the joints you think of in the human body. And this is where bones are separated by a joint cavity. And these are going to be the diarthrosis joints, freely movable. And they all contain some pretty basic features. You've got an articular capsule and a joint cavity. You've got synovial fluid. You have articular cartilage. And you've got ligaments, nerves, and blood vessels. So we're going to break this down even more in depth going through the next few slides. So here's what we're talking about. We've got our bone and this other bone here, and we're meeting at this joint. How does that work? Well, first, we've got to have this articulating cartilage, also called hyaline cartilage, where the two bone surfaces would touch. Then we've got this cavity here that is going to be filled with fluid to help lubricate this area. And we've got, of course, these ligaments on the outside. That is what is containing or making this joint capsule. Okay, so let's look at these features and how these synovial joints work now that we've got that video that gave us the broad overview. So first, if we look at the anatomy of the joint, it is this double-layered joint capsule called the articular capsule. The outer fibrous layer is dense connective tissue that's going to strengthen the joint and stop the bones from being pulled apart. The inside layer is the intersynovial membrane. That is going to be made of areolar connective tissue. It's going to cover the internal joint surfaces that are not covered in cartilage. And this is the membrane that will make the synovial fluid. Of course, you've got articular cartilage, which is also called hyaline cartilage. That's what it's made of. That is on the bone surfaces at the joint. The articular cartilage's main job is to reduce friction during movement, to be a cushion to absorb joint compression, and to prevent any damage to the ends of the bones. That area does not have the perichondrium and is avascular. So if you damage that cartilage, it cannot repair itself. It doesn't have the perichondrium we learned about in the last chapter, where we can regenerate the cells, and it's not vascular. It doesn't have blood vessels, capillaries going to and from it to give it nutrients and things to grow. Then you've got the joint cavity, which is the space between the articulating bones. It is lined by the synovial membrane and makes the synovial fluid. Synovial fluid is very thick and viscous. It's kind of oily. Its main job is to lubricate the cartilage on any of the surfaces that are going to be touching. It's going to nourish and remove waste from that articular cartilage, and it is a shock absorber. The ligaments connect bone to other bone. That's dense, regular connective tissue. It is going to stabilize, strengthen, and reinforce these joints. You can have extrinsic ligaments, which physically separate from the joint capsule, and then intrinsic ligaments that is actually going to thicken the capsule itself. So that can be ligaments outside and inside that capsule. You do have nerves and blood vessels. There is nerves that detect painful stimuli and report on movement and stretch. You'll also have tendons. Tendons are composed of dense regular connective tissue that's going to attach muscle to the bone. It's not part of the joint itself, but it's accessory to it, and it will stabilize the joint. You also have to talk about something called bursa, and that is this fibrous bag or sac-like structure that has synovial fluid. It's lined internally by the synovial membrane, and it's found in synovial joints where there are bones, ligaments, muscle, skin, or tendons that have a tendency to rub together. And really, they can be connected or separate, and their main job is to alleviate friction. The bursa can become inflamed itself. It's called bursitis. And if you've ever suffered that, it's pretty painful. It's like in your shoulders, or that's where I've had it before. When you overuse the joint, you can inflame those little sacs of synovial fluid, whose main job is there to prevent friction and prevent inflammation. So here's what we're talking about with the bursa, like on your knee. Here it is to have that gastrocnemius muscle. It's going to come and attach there to this joint. You have it in the back as well, or sorry, in the front for the patella. This is in the back where the ligaments will be attaching and the kneecap is attaching. So you've got this like extra cushion at places where there's more than one thing attaching, just as a way to reduce the friction. Okay. Some other accessory structures not found in every joint, but found in enough joints that we need to talk about it before we can talk about exactly how the joints are moving. You have tendon sheaths, which is just really long bursa that will wrap around tendons where you get a lot of friction. This is really common in your ankles and your wrists. You can also have fat pads that act more like a protective packing material and fill the spaces when a joint changes shape. And that's really common, again, sort of like in your hands or your feet. And you can see here, like it's wrapped around the tendons. Okay. So now, how we classify it is based on the shape as well as based on how it moves. And that's what that video kind of showed us. So let's go ahead and get right into it. Uniaxial joints, the bone can just move on one plane or one axis. Think like a unicycle with one wheel. This is uniaxial joint, moves in one axis or one plane. Biaxial is the bones can move in two planes or two axes. Multiaxial is more than one axis, or I guess more than two axes or planes. The shape is also important. We have plane joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket joints. And their shape will often determine how or like what axes or planes they can move on. So a plane joint, we've got the articular surface flat. It's the simplest, it's the least mobile synovial joint, and it has a limited side-to-side gliding movement. You can also end up with a hinge joint where you've got one surface that's sort of shaped like a little bowl and the other sort of fits into it like a little, I guess, knob. So you've got the convex, little knob shape, and concave depression, and it sort of acts like a hinge on a door. You can then get a pivot joint. That's where a bone with a rounded surface fits into this ligament ring. And that is also a uniaxial joint where you have this longitudinal axis, which all sounds like it doesn't make a lot of sense, but you'll see shortly the picture that we're looking at there, and it will make more sense. You can have a condylar joint. That's this oval convex surface articulated with a concave surface, and that can go on two axes. So it's a biaxial joint. A really good example is like your knuckles. You can have a saddle joint that is like a saddle shape to it. It's also biaxial. And that's can be found in some joints in your wrist, like your metacarpal. So you can move your thumb toward your other fingers as well as like grasping stuff. And then a ball and socket joint, that's a spherical head fitting into a cup-like socket, multi-axial, most freely moving. Think of like your hip or your shoulder. So gliding is when two opposing surfaces slide back and forth or side to side. And this is the only movement that is possible, but it is in any direction. And we find this really just in the hands and feet. But it is a type of movement that is really not discussed in our types of joints, but is sort of a rare case. Okay, now we need to talk about the types of motion, which sort of gets into like a little bit of a physics thing. But really, when we're talking about angular motion, we just want to know, do we increase or decrease the angle between the two bones. So if I hold my arm out flat in front of me and I bend my elbow, am I increasing the angle between the bones in my forearm and the bone in my upper arm, or am I decreasing it? Like, what is happening? And so the specific words that we use are flexion and extension, hyperextension, lateral flexion, abduction and adduction, and circumduction. So flexion is moving in an anterior posterior plane. We are going to decrease the angle between bones or bring them closer together. A great example is if you put your hand in front of you and you bend your finger. Extension is in that same anterior posterior plane, but it's the opposite. You are increasing the angle between the bones. So you take your finger that you just bent and you straighten it out. That is an extension. Hyperextension, we normally think of that as sort of a bad thing. That's when you extend it past 180 degrees. And that can be a bad thing, like if you bend your finger back, towards your outside of your hand, or like, you pop your knee too far. But it's also one that is normal in, like, if you have your head level and then you look up to see the ceiling. That's a hyperextension. A lateral flexion is the trunk of the body moving in this coronal plane laterally. And that one's sort of hard to see, but that's like your vertebrae in your cervical and lumbar region. Like, you can sit up and try to notice that your trunk of your body is moving like laterally in the coronal plane. Okay. So here we go. Here's a picture. Okay, so flexion would be looking down with your chin touching your chest. Extending it is bringing it to a neutral position, and then hyperextension would be backwards, right? Flexion, bringing your arm up towards your shoulder. Extension, bringing it down. Hyperextension, again, like if you take your hand and you pull it up back towards the forearm. Can do this with your legs as well. And then the lateral flexion, you sit up straight and you sort of bend laterally. Okay. We also have to talk about abduction and adduction. Abduction with a B, that's the lateral movement of the body away from your midline. So you're taking your arm or you're taking your thigh and you're moving it away from the midline. Then adduction is the medial movement of the body to the midline. So you're bringing your arm and thigh back towards your body. And so I sort of like to think of this is for adduction, start with your arms like out, like you're the letter T. You look like a plus sign. You're bringing your arms back down. That's adding to your body. Abduction, you stand with your arms in a T and you bring them up towards your head and your neck like you're being abducted by an alien, right? You're going up. If that works for you, great, use it. If not, I'm so sorry. You can do this with any part of your body, right? You can adduct your hip and bring it closer to your body, closer to your other leg, or that's add with D, or you can abduct your leg and bring it away from your other leg, put your hip outwards. Okay. Circumduction, this is one of these weird ones, but it is when you take the proximal end of an appendage and you keep it still, and then the distal end can make a circle. And this makes this pretend imaginary cone shape. An example is like taking a marker to draw a big circle on a chalkboard. But you can do that with your arm. If you hold your arm out to the side and do a big arm circle, that's circumduction. Okay. And there's more. So that rotating motion has its own set of vocabulary as well. That is where the bone is going to pivot on its longitudinal axis. You first have lateral rotation, and that is turns the anterior surface of the bone laterally. So turning it away. You can have medial rotation where you turn the bone medially or towards the center. You can have pronation, and that is like a type of medial rotation. An example is taking your forearm, so the palm of the hand is posterior. And then supination, where you laterally rotate it so that the palm is anterior. So what does that look like? Rotation, of course, is just like moving it on that axis, right? So like shaking your head to say no. Lateral rotation would be like if you took your arm and you rotate your arm outward away from your body. Medial is rotating it in. Same with your legs. You can rotate inwards, and then that would be medially, or outwards, and that is laterally. Pronation is when you're sort of spinning the hand so that it is going to face posteriorly. Supination is rotating it so it faces anteriorly. Okay. Special movements that don't really fit anything else but exist. Depression. That is inferiorly moving a body part. Great example is when your mandible is working to open your mouth. It is depressing, it's moving down. Elevation is when you're superiorly moving the body part, like when you're closing your mouth. Or like your shoulders, if you bring them up towards your ears and then you drop them down. That is an example of elevation and depression. Okay. Okay. Your feet have slightly different vocabulary words in which you can dorsiflex. That's your ankle. That is where you bend at your ankle joint so that the surface of your foot moves towards the leg, like you're digging your heels in. Plantar flexion is when you bend that same ankle joint so that you're pushing your toes down, like a ballerina on tiptoes. You can also have eversion. Eversion is where you keep like your big toe on the ground, but you rotate so that the rest of your toes come off the ground. And then inversion is where you keep your pinky toe on the ground and you rotate so that the rest of your foot is pointing inwards. These are really just used for your feet at your ankle joints. But if you're someone who like runs or does any other, like even weightlifting, the inversion, eversion, dorsiflexion, that stuff, it comes up because you can get special shoes and you have special stances that you practice so that you are keeping those parts of your body neutral and getting the best performance. Okay. Another special vocab is protraction and retraction. Protraction is sort of like jutting forward. It's the anterior movement away from this anatomic position, like sticking your jaw out. Retraction is then pulling it back. Opposition and reposition are special movements for your hands. And it's one of the things that makes us special, I guess, in the animal world, because even primates can struggle with this. So this is really like what makes a human super special. This right here. Opposition is the movement of your thumb towards the tip of your fingers at this carpo-metacarpal joint. So the ability for you to grasp objects is because of opposition. And then reposition is the opposite movement of bringing your thumb back out to make your hand flat. But you can grasp things because of opposition and reposition. All right. All right, so that song sounds silly, but maybe you get up and, do the motions. Just like with the anatomical position vocab words and the plain vocab words from the very first chapter, knowing how these motions are, like what they mean, is incredibly important moving forward. Nothing else will make sense if you do not know what extension is, or adduction is, or plantar flexion is. So spend some time with these vocabulary words. They're a little weird. Some of them are intuitive, some of them are not. If the song helps, use the song. If the song doesn't help, don't use the song. Whatever you need to do to get these down back and forth, you know, it's important. And, pause this video now and do that, because nothing else in this chapter will make sense without those vocab words. Not to be dramatic, but it is true. It'll be a lot of gibberish, maybe more than usual. Okay, so we're going to move on with me making this video, but feel free to review as you need. Okay, levers. We talked very, very briefly about levers as we talked about the bones, just that they are a lever for our muscles. But what does this all mean? A lever is just this elongated, rigid object. It has a fulcrum, which is this fixed point that the lever moves around. You have to apply effort at one point, and then you'll get resistance at a different point. If the effort exceeds the resistance, you will get movement. We have what we call an effort arm. That is the part of the lever from the fulcrum to the point of effort. So we can measure that. You have the resistance arm, which is the part of the lever from the fulcrum to the point of resistance, and you can measure that. Let's look at different types of levers. So the first one is that we have a first class lever. A first class lever has the fulcrum in the middle between the effort and the resistance. A pair of scissors is a really great example because you're applying the effort to the handle, and there is resistance at the cutting edge of the scissors. Okay. And a really great joint is what we call the atlanto-occipital, or like the atlas occipital joint of your neck. Um, and basically what that means is that there's this muscle on the side of the neck that has the effort to pull. And then you have, of course, in the opposite direction, the resistance from the muscles in the front. But it's what is allowing your head to look upwards or to then look downwards. So this joint here has this first class lever in which you are applying the effort, you're applying the resistance, or there is the resistance. Okay. Second class lever, that is where there is the fulcrum, or I guess the resistance is between the fulcrum and the effort. An example of this is lifting the handles of a wheelbarrow so that it can go on its wheel. And basically the load of that wheelbarrow is the resistance, right? Whatever you put into it is the resistance, the heavy part. You have got to apply effort to the handles, and then that fulcrum is at the wheel. So the fulcrum is far away from the effort. This is kind of rare in the human body. We don't see it often, but an example is when you plantar flex your foot, you can stand on your tiptoes. So your calf muscle is contracting, and this is going to cause a pull, and that is what lets you, lift up your heel to stand on your toes. Then we've got our third class lever. This is where you've got this applied effort between the resistance and the fulcrum. And a great example is tweezers or forceps, right? You pinch the tweezers or the forceps sort of in the middle. The resistance is on the object. And of course, the fulcrum is like where the tweezers come together. This is super common in the human body. And a great example is your elbow joint. So that joint is actually the fulcrum. You've got your biceps applying effort. You've got whatever is in your hand being the weight providing the resistance. Okay. Why did we talk about all of that? Well, now we're going to talk about specific joints. And we're going to look at those joints and classify them as what kind of joint they are, what kind of movement they have, and what sort of lever they might be. And that's really how we look at joints as anatomists and physiologists, because we've got what they are and then we got how they move. So we'll start with the temporal mandibular joint, also called TMJ. That is where the head of the mandible articulates with your temporal bone. This is the only mobile joint between the bones and the skull, right? The rest of them, we said, were those synaorthosis joints, the sutures, they don't move. This TMJ joint has a very loose articular capsule that surrounds the joint. It allows for an extensive range of motion, and you can even practice this now, right? You can do that protraction, retraction, you can depress, you can elevate, you can kind of move it in like a circle, you can do all of those ranges of motions. There is an articular disc that is a thick pad of fibrocartilage, and it's going to divide the synovial cavity into two different chambers. What are the ligaments that we find here? You've got your sphenomandibular ligament that extends anteriorly and inferiorly from your sphenoid. That's a bone right in your skull to your mandible. And you've got the temporal mandibular ligament that is going to be from the tubercle to the mandible. How does it move? Well, it has hinge, gliding, and some pivot movements, right? It functions like a hinge when we're doing jaw depression and elevation, and it glides for protraction, for biting, and then side to side grinding. Right? So here is that joint. And right, it's a hinge when it's going up and down. It glides when we're going sort of forward, backward, side to side. TMJ disorders are fairly common. And, chances are many of us in this class right now actually have issues with this. If you feel like a popping or a pain when you open your mouth, that's a TMJ disorder. But it's common because of the alteration of ligaments and their securing point. If that articular disc is out of its normal position, you get that clicking or popping, pain in the joint, in the sinuses, in your ears, in your oral cavity. You can have it in your eyes and in your teeth. And then I guess, how do you combat that? Well, there's a lot of like physical therapy, massage. If it's really bad, though, surgery is an option. Okay, your shoulder. Let's move on to that already. Um, that is your sternoclavicular joint. It's a saddle joint. It's formed by your mandiburum and your sternal end of your clavicle. So, right, your front part of your clavicle. And it has this articular disc that has partitions into two parts, forming two synovial cavities. How can you move this joint? Well, you can elevate, depress, and circumduction. Its stability is there because of different fibers and ligaments, and it makes this joint stable and difficult to dislocate. Okay, so that's your front, your clavicle attaching, keeping your shoulder in place. Of course, if you break that clavicle, that will dislocate that joint and is rather painful. Okay, your acromioclavicle joint, that's the back, that's a plain joint. That's formed from your acromion and the lateral surface of the clavicle. And that is going to have this fibrocartilaginous articular disc. It is going to be strengthened by the acromioclavicular ligament. The clavicle is bound to the coracoid process. And if torn, the clavicle no longer is aligned and you've got shoulder separation. Okay. Then your glenohumeral shoulder joint, that's the inside sort of part where you've got the ball and socket joint that's formed by the head of the humerus and the glenoid cavity of the scapula. That's what allows the greatest range of motion of any joint in the body. That's your allowing circumduction. You've got the glenoid labrum is inside that socket. You have a lot of bursae. So if you have bursitis, or that is inflaming that bursa, and its job is really just to decrease the friction across that capsule. You've got a lot of supporting ligaments and tendons that are there. It is not incredibly important for our purposes that you memorize each and every one of them, but just knowing that they exist is good. And you've got, of course, the tendon of the biceps brachii there as well. This is going to have stability because of the rotator cuff muscles. We're going to talk about muscles in the next chapters, but their job is to hold the head of your humerus into that cavity. And of course, you've got tendons around it making that articular capsule. So here's what that looks like. So you've got this ball and socket joint here. Holding your shoulder in place, allowing for extension, for flexion, for circumduction, all of that from this joint. And here's what it looks like if you were to sort of cut a a cross section to look specifically into that joint where you've got your you've got all these tendons holding them there. You've got the bursa, you've got the articular capsule. Okay, what can happen here? Well, if you've got instability, you can have shoulder separation from that acromion clavicular dislocation, and you'll feel pain when you move your arm as an abduction more than 90 degrees. You can also have a dislocation when you hit a fully abducted humerus hard, and then the shoulders will sort of appear flattened and squared off. It's out of that socket, basically. Okay, elbow joint. Elbow joint is a hinge joint. It has two articulations because you've got your ulna and your radius. You've got the trochlear notch of the ulna articulating with the trochlea of the humerus. You've got the capitulum of the humerus articulating with the head of the radius. Both of these are going to be in one singular articular capsule. And here's what we've got going on there. And you can see your elbow joint is allowing for flexion and extension most commonly, but you'll see that we have quite a few ligaments here as well. Again, for our purposes in lecture, knowing every single ligament and where it attaches is not necessary, but knowing that they exist is useful. Okay. And here's what it would look like medially or a sagittal section of it. We can see this singular articular capsule where we've got the trochlea here in our trochlear notch and the head of that radius all meeting together. The elbow is very stable. It has that very thick capsule. The bony surfaces lock very closely, almost like little puzzle pieces. You've got a lot of ligaments there, the radial collateral ligament, the ulnar collateral ligament, and the annular ligament, all surrounding and binding them together. So this is really a very stable joint. You can have partial dislocation. We call that subluxation. And that could be where the head of it is pulled out of the annular ligament. Really, we only find this happening in kids. And that's because that is not a fully formed ligament yet. And what ends up happening is the doctor just sort of maneuvers it back into place. Hip joints. Hip joints is an articulation between the femur and the acetabulum of os coxa. I know, what a nice word. But you've got this acetabular labrum, which is just this ring of fibrocartilage that helps to deepen the socket. And it is more stable and less mobile than the shoulder joint. Okay, so that's happening here. This head is fitting into this socket, and then we've got the ligaments holding it in place. Again, for our purposes here in lecture, knowing each and every single ligament and where it attaches is not important. Knowing that they exist is the important part. But your hip joint allows for flexion, extension, abduction, and adduction, and that special circumduction as well. Here's what it would look like from a cross section. You can see that we've got the head of this femur going into this socket here in your os coccyx. You've got this ligament attaching from the femur to the bones here, as well as from the acetabellum and the ischium and ilium here. So this inside ligament of the head of the femur, that's really the one that's holding it like to that socket, but these other ones are reinforcing it. Let's see. We just said all of those in words. You also have the retinacular fibers that are around the neck of the femur, and that's also where there's arteries to supply blood to the femoral head and neck. So that's our one new thing. This is what I just said in the previous slide. You've got these different ligaments, the iliofemoral ligament providing anterior support, the ischiofemoral ligament, which is posterior located, and the pubofemoral ligament is really just this sort of triangle shape. And these become taut when the hip is extended. And the ligamentum teres, or the ligament of the head of the femur, that is a small ligament that is going into that socket. It's not providing strength, but it's very important in supplying the arteries to the head of the femur. So what can happen when you fracture your hip? Really, you could break the bones, but more often we're talking about these ligaments and things happening to them. So you can have this intro canicular fractures, which is in young and middle-aged people, or a subcapital fracture, which is within that capsule. And that's what's happening to elderly people with osteoporosis. And if you tear those arteries, you can actually have necrosis to the hip, which is a much larger problem than just those ligaments being damaged. Obviously, tissue death is more serious. Okay, the knee joint. You will spend a lot of time in lab as well as here talking specifically about your knee. That is the largest and most complex diarthrosis. Primarily, the knee is a hinge joint. It is capable of slight rotation and slight lateral gliding when it's flexed. And there's really two articulations that we're looking at. You're looking at the tibiofemoral joint, so between the condyles of your femur and the condyles of the tibia, as well as the patellofemoral joint between your patella and the surface of the femur. Okay, so it's mostly allowing for flexion and extension, but of course, we do have a little bit of gliding as well. And the knee, we know, has a lot of ligaments attached to it, keeping it stable, but allowing for these motions. Really, what we want to do is take away all that outside stuff and look at the anterior and posterior, deep inside those articulating cartilage places. So of course, we've got your femur and you've got the condyles there, and you've got your tibia and the condyles there. And you'll see that you have this meniscus. You can have the medial meniscus, the lateral meniscus, and then you've got the ligaments associated, the anterior cruciate ligament, or ACL, the MCL as well, and then this fibular collateral ligament and tibular collateral ligament. All of those are responsible for holding this joint in place. Okay. You also will have tendons, where you will have the tendons going from the quadriceps over the knee to surround the patella. So that is your patellar ligament. And then, of course, your fibular collateral ligament from the femur to the fibula to prevent hyperadduction. So what do all of these ligaments do? Your TCL is going to reinforce the medial surface, goes from the femur to the tibia, prevents hyperadduction. The medial meniscus and lateral meniscus is this pad of cartilage that is going to cushion the joint, the articular surfaces, and it's going to change shape. Then your ligaments, your ACL, that is going to extend from the femur to the tibia to prevent hyperextension. And then the PCL is going from the femur to the tibia to prevent hyperflexion. So, complicated, yes, which means injuries. If you've played a sport in your life, you may have encountered this. Your tibial collateral ligament injury happens when you forcibly adduct away from the body. The fibular collateral ligament is when the medial side is hit. You can have an ACL injury when you hyperextend, a PCL injury when you hyperflex, meniscus injury from trauma or just overuse, and we have what is sort of nicknamed this unhappy triad, where you've got an injury to your tibial collateral ligament, medial meniscus, and ACL. This happens a lot in sports where you get a hit to the knee that adducts it, that abducts it while it's rotating. And a lot of this injury to the knee, the only solution is surgery. Again, we know that those cartilage inside the joint, as well as ligaments and tendons, they do not have the vascular system to heal quickly on their own. So surgery is sometimes the only option to correct these injuries. Okay, ankle joints, we call it the talocrural joint. It's a modified hinge joint. It is going to allow for dorsiflexion and plantar flexion. There are two articulations in one capsule. You've got the tibia to the talus, and you've got the fibula to the talus. And that's what we've got going on here. Tibia and fibula to the talus. And here's what you're seeing sideways. Again, all of these individual joints and ligaments. For the foot and ankle, not necessary for you to know exactly where they are and what they are for lecture. I cannot speak on your lab, but just knowing that there are these ligaments that exist, that's the important part. Okay, so you're going to have these malleoli in order to prevent sliding on this joint. The articular capsule is going to cover that tibia, cover the media malleolus and the lateral malleolus and the talus. You've got your deltoid ligament to bind the tibia to the foot to prevent over-eversion, so you're not totally bending your foot out or in on our next one. Your lateral ligaments to prevent the foot from the lateral side from over-inversion. If you get a sprain or a tear, it's most often in that lateral ligament that prevents over-inversion. So a sprain, of course, is the stretching and tearing of those ligaments without a fracture or dislocation, usually from over-inversion. If you, of course, totally tear these ligaments, then surgery is usually the only option. If you just really stretch them, it's, rest and ice. A Pott's fracture occurs with over-eversion, and that is when the talus moves laterally and actually fractures your fibula. Okay, what happens as joints age? So when we develop a joint, that's usually from the 6th week of embryo development. If it's going to be a future fibrous joint, then the mesenchyme is going to turn into dense regular connective tissue. If it's going to be a cartilaginous joint, it is going to differentiate into fibrocartilage and hyaline cartilage. If it's a synovial joint, if it's laterally placed mesenchyme, it makes the articular capsule. The next layer of mesenchyme makes the synovial membrane. And if it's centrally located, then it's going to be reabsorbed and make any meniscus or articular discs. After that, obviously, there are things that can happen as we get older. So the first being arthritis, rheumatic disease involving damage to articular cartilage. You can have osteoarthritis, which is a problem in an aging joint because of wear and tear. So rheumatoid arthritis is damaging the cartilage. Osteoarthritis is because of aging, the wear and tear to the joint. When we exercise, we do increase synovial fluid, which will then get to the chondrocytes. We strengthen muscles that support and stabilize joints. But in extreme cases, you can actually aggravate the joint and create problems that can worsen osteoarthritis. So again, rheumatoid arthritis, that's more of a genetic based thing, damaging the cartilage. Osteoarthritis happens as you wear and tear. Some different clinical views here, exactly what we're looking at. Arthritis as a whole, we just call it inflammation or degenerative diseases of joints. And the symptoms we see are joint swelling, pain, and stiffness. We can get gouty arthritis, which is usually seen in middle-aged and older men because of an increased level of uric acid. Osteoarthritis, that is usually seen in older individuals by the wear and tear of their cartilage. And we see this often in fingers, knuckles, hips, knees, shoulders. Rheumatoid arthritis, that's in younger people, middle-aged adults, usually in women. That's an autoimmune disorder, and that starts with synovial membrane inflammation and then damage to the articular cartilage. All right, guys. So hopefully you're really excited too that I learned how to embed videos so you don't have to click somewhere separate to watch them. However, you can click in the D2L. They are saved under extra resources. And if you have any questions, of course, feel free to reach out to me. I'm happy to help you in any way. Otherwise, thank you for watching, and I hope that you have a wonderful day.